Thank you very much for the introduction. Today, I'm going to be talking to you about some strategies that I try to use to help transition patients safely from hospital to home. I have no disclosures. So, a brief outline, I'll talk a little bit about heart failure readmissions and then go over 3 case studies, talk about some additional general tips, and then a summary. And today, I'm hoping that this talk will refamiliarize yourselves with some tips to safely transition patients home from hospital after a heart failure admission, and to refresh your memories of common reasons for heart failure admissions. So when we look at data from 2018 in the ADHERE registry, we can see that readmission rates for heart failure within 30 days average around 20 to 25%. And common reasons can include progression of disease, recurrent heart failure, acute kidney injury, psychosocial issues such as not being able to afford their medications or stopping their medications, non-adherence to self-care management strategies, many non-cardiac reasons, and arrhythmias. So case study number 1 is that of a 90-year-old gentleman with heart failure and mid-range ejection fraction who lives in a nursing home. And he has a history of CKD, atrial fibrillation, sick sinus syndrome, and treated hypertension. And he's admitted to the EP service with an infected pacemaker lead. He's noted to be volume overloaded with worsening peripheral edema, and the Lasix is increased from 20 milligrams once a day to 40 milligrams once a day. He's discharged home, but he's not fully diuresed. So he's readmitted 3 weeks later with decompensated heart failure, and his admission labs and vitals are as stated. He gets admitted for decongestion with IV Lasix, and on day 4 of his admission, he's seen in consult by the heart failure team who suggest initiation of spironolactone for optimization of his guideline-directed medical therapy and enrollment in remote monitoring Medley ICC at discharge. And I know that Mary spoke about Medley in an earlier talk. So on day 8 of his admission, he has some acute kidney injury with creatinine rising up to 252. And his Lasix is held for 2 days. Creatinine gets better and his weight stays relatively stable. So on the day of discharge, his Lasix is restarted at 40 milligrams twice a day. And recall that his prior dose of Lasix was 20 milligrams once a day. He started on spironolactone and potassium and continued on valsartan and Norvasc. He gets enrolled in Medley ICC and he's discharged back to his nursing home. So on day 3 post-discharge, his blood pressure is now 70/43. He can't stand up, he's unsteady. We can't obtain any weights due to how unsteady he is. And he actually has 2 falls due to his low blood pressure, and thankfully he's not injured. So the nursing home is calling the Medley coordinator for advice. So several phone calls later between the heart failure MD, the Medley coordinator, and the nursing home, a decision's made to hold the valsartan, the Norvasc, the Lasix, the spironolactone, and the potassium. So for the next several days, there's 1 to 2 phone calls at least daily that are required to adjust medications and request community lab work. He has some outpatient blood work that shows a rising creatinine to 194, and he requires an urgent face-to-face follow-up visit in the heart function clinic earlier than was previously scheduled. His son's unable to visit him in the nursing home due to COVID-19, so he can't help with any of these issues, and he can't help his dad with his care. And we know that when we have to hold medications entirely, it means that they will also need to be reintroduced gradually. So in this case, the patient was originally discharged home, still volume overloaded, and this often leads to an unsuccessful discharge. If the patient's weight is significantly rising prior to discharge or still high, it's probably not the right time to send them home. If they're volume overloaded and they have gut edema, then often oral Lasix isn't absorbed and they'll fail the transition from IV to oral. If a clear precipitant for admission is identified, such as new atrial fib, and the precipitation is completely resolved, for example, they have a successful DC cardioversion, then a higher dose of Lasix may not be needed. If there's no clear precipitant identified, then an increased dose in the base diuretic is required, or the patient will likely just reaccumulate fluid again. We have to be careful not to over or underdose. So if their previous home dose was 40 twice a day, an appropriate new dose might be either 60 twice a day or 80 twice a day. And it's unlikely going to need something like 120 twice a day and adding in metolazone. And this patient was actually sent home on about a 75% higher dose of Lasix from 20 once a day to 40 twice a day. And that was not trialed in hospital. And it was also started immediately after an episode of acute kidney injury. Patient additionally was sent home on brand new medications, an MRA and potassium supplements that were started on the day of discharge. And this is generally not a good idea, as we don't know how patients will respond sometimes to medications. And finally, there was no plan for repeat outpatient labs for this patient. And CCC guidelines certainly recommend the reassessment of renal function and potassium following the initiation or uptitration of these medications. Case study number 2 is that of a 38-year-old man who's admitted to hospital with newly diagnosed heart failure and reduced ejection fraction. He has a history of asthma and diabetes, and he's only taking inhalers and metformin. He's diuresed, and he's found to be tachycardic with a heart rate in the 130 range. He's in sinus, and his length of stay is only about 5 days. He's discharged on bisoprolol 5, Lasix 20 once a day, and mid-range Entresto, spironolactone 25, and ivabradine 7.5 BID. You see him in your office 3 days after discharge because he's still complaining of shortness of breath, swollen ankles, and fatigue, and you find that he's hypotensive and cool to the touch, so you send him to the ER where he's readmitted in cardiogenic shock. It's very, very easy to underestimate how sick a young person is. They often present as if they're medically stable, but in fact can be much sicker than they appear. And by the time they're complaining of symptoms, they're often far along in their heart failure decompensation trajectory and can deteriorate rapidly. In fact, many young patients who actually present with shortness of breath are treated for asthma, pneumonia, or other lung conditions. And heart failure, while rarer in young patients, really does still need to be on the differential for anyone who's presenting with shortness of breath. So in general, we would tend to initiate guideline-directed medical therapy at low doses and uptitrate slowly over days to weeks. Tachycardia is often seen. It's a compensatory response to decreased cardiac output, and aggressively trying to slow someone's heart rate can actually make them sicker. We'll diurese them first and then initiate beta blockers when they're eubulemic. In this case, this patient was started very aggressively on almost every conceivable medication used to treat heart failure. And I think that the take-home message here is that if you see a patient in your office with a new diagnosis of heart failure and reduced ejection fraction, know that these medications are all appropriate to use to treat and manage heart failure, but generally speaking, a slower uptitration is often safer versus a rapid initiation of everything all at once. Case study number 3 is that of a 72-year-old woman with an ischemic cardiomyopathy admitted with heart failure and new atrial fibrillation. Her medical history is significant for some mild cognitive impairment, CKD, PVD, sleep apnea, and hypertension. And she's seen by the hospital pharmacist for med reconciliation. And the pharmacist finds that the patient isn't really able to give a great history regarding her medications. She ends up having a complex and prolonged admission that's made more challenging during COVID-19 and that her family can't visit. She has multiple changes to her medications made during the admission, including being started on warfarin. So COVID-19 has definitely made involving a patient's support network in their care much more difficult. And we've had to be creative in order to engage them. So often what I do is I'll put my phone on speakerphone when I'm in seeing the patient so that I can help to engage the family so that they're understanding of the plan of care, medical updates, aware of heart failure self-care management strategies, and make sure that they understand what the discharge plan is. 4 ears are always better than 2. And we know that patients who are admitted to hospital and not feeling well often just don't really absorb all of the information that they're given. In this case, the patient was willing to make the change to blister packs, and the pharmacy could provide the service. Blister packs may help decrease confusion about what to take when and improve compliance. Often these prescriptions are needed in the pharmacy a day in advance, so it's important to ask what their requirements are. In general, faxing prescriptions can facilitate medication adherence and improve communication between hospitals and community partners, particularly when there have been multiple medication changes. In this way, prescriptions don't get lost, and there's not a delay waiting for the patient to get home and then to get into the pharmacy to get them filled. As well, with COVID-19, we're often asking if pharmacies will deliver. It's important to check what the pharmacy hours are. There's nothing worse than sending someone home on a Saturday only to find out their pharmacy's not open on Sunday. And sometimes we make changes to patients' medications, such as increasing ramipril from 2.5 to 5, and we just verbally tell patients to double their dose, but they're not given a written prescription. This also can lead to confusion at the community pharmacy, so we really need accurate, complete prescriptions for clear communication. I always get our hospital pharmacists to see patients at discharge, again, for the provision of written and verbal information about their medications, and we give them a chart that indicates the suggested time of day they should take their medications. When I put someone newly on warfarin, I always call the GP's office to let them know that they're newly started on warfarin, and the family's going to be calling to get a lab requisition for INR monitoring. And then, of course, make sure that the patient and the family understand that they too need to do this. Finally, what's helpful is using members of our multidisciplinary team to help with patient education, as they all have their areas of expertise. We've previously completed a quality improvement project streamlining our follow-up post-discharge planning. We endeavor to see all of our patients within 2 weeks, which meet CCC guidelines. We make sure that the patients have the clinic telephone number written down so they know who to call if they need to change or cancel an appointment, or contact one of the MDs or the NPs if they've got medical issues. I try to include what I think are important details in the letter, like what the hospital blood pressure target range was, what the target weight is, what the creatinine levels were, medication intolerances and why, as well as important information such as follow-up with who and when. Our discharge letters allow us to use PODs, which are patient-oriented discharge summaries, which provide education that's written in a language for patients, as opposed to the medical jargon that we often use in a formal discharge letter. PODs includes information on heart failure self-care management, follow-up appointments, and has a link to our Ted Rogers Heart Failure Educational website, and they're available for multiple different types of medical conditions beyond just heart failure. I always provide patients with 2 paper copies of their discharge letter with instructions to take one in hand to the family doctor's follow-up appointment in order to facilitate communication. And I like for them to have another copy on hand in case they go in to see another healthcare provider, or if they've got home care services, or if they end up in an ER somewhere, then they have a clear letter for the healthcare providers to see. We give patients a lab requisition and have a plan for outpatient blood work, and we'll enroll them in remote monitoring if it's appropriate. Finally, some additional tips. You can expect to see a 20 to 30% rise in someone's creatinine if you initiate or increase an ACE, ARB, or Entresto, and this is not uncommon and it doesn't require dose adjustment. If the rise is significantly higher, then a slight reduction in the dose, such as going from ramipril 10 to 7.5, is more appropriate than full discontinuation, and then recheck the blood work. Many patients with heart failure have chronically low blood pressures in the high 80s or 90s, and that's normal for them, and it doesn't require adjustment or discontinuation of medications if they're asymptomatic. If they're mildly symptomatic, what we suggest is spreading out over the day the medications that can lower blood pressure. So, for example, some in the morning and some at nighttime, or more at night when it's less bothersome to patients. And finally, it's important to ask your patient whether they can afford their medications. Do they have drug coverage? Because there's no point in prescribing a medication to a patient that they can't afford to pay. So finally, what I think is important is to try to communicate and engage all appropriate members of the patient circle of care, family, support networks, family doctor, LIN, and community pharmacy, to avoid making drastic changes in their medications on the day of discharge, to try and ensure that patients' families understand who to call and when if things aren't going well, and to make sure that they leave hospital with a booked follow-up appointment. And that sometimes, despite all of our best efforts, patients are going to need to be readmitted. And certainly, if I knew all that there was to know about how to prevent readmissions, I'd probably be a billionaire and I wouldn't necessarily need to work anymore. Thanks very much.